All right, it is November, the 23rd, 2020, Monday. We are continuing on with the election with, did I say election? Even though that's still going on. Continuing on with the lecture for pharmacology, Airway Pharmacology. Again, we're going to start off with going over some of those drug dose calculations that I gave you, and we'll go from there, okay? If any questions on any of them, we can go from there, okay? So let me pull up the drug dose calculations worksheet. Again, I told you guys that I will give you the answers. So the answer key is also there, but I want to know if you worked them out without using the answer key, or when you did it, you see what you did wrong and you understand it. Now, so are there any questions on any of these that you could not figure out on your own?
Yeah, number 7.
Yes, number 7, I gave y'all some instructions on. Don't worry about number 7. Number 7 is the only one I told you. Don't worry about that one because it's got dilutions in it, and we're not doing dilutions. Don't worry about number 7. Any other than number 7? All right. Well, so everybody understands all of the other ones. You got them and you understand them. Okay, good, good. It's not that hard. It's just that, you know, you got to be able to do this. You know what I'm saying? So when you get home and start looking at your drug, did anybody go home and look at your medicine cabinet? Or if you gave somebody some medicine, you kind of looked at the concentration and active ingredient and dosage and all that kind of stuff that you were able to, oh, okay, I see how they figured that out, or I know how much to give my mom or dad or child or whatever in the case of them needing some medicine. All right, so I want you to also understand that when we talk about the milligrams over cc's equals milligrams over cc's, that can also be done in pills, okay? You can also look at that as pills. So if you look at this right here where it says concentration over 1 cc, this could also be over 1 pill, okay? And so you have a desired amount over desired amount of pills, right? And so, you know, if the doctor said, I want you to give 2 pills at a concentration of 0.5% concentration, right? Then what, you know, if it's 5 milligrams for every pill, and if I give you 2 pills, and of course you would have 10 milligrams, right? So you can use the same thing, even if you're looking at pills. It doesn't have to be liquid medicine, okay? It could be pills, because sometimes you take half a pill. If it's half a cc, then, you know, you can give half a pill, 4 quarters of a pill. It depends on how much you have to give. But this calculations shortcut should be, you keep this with you at all times. Yes, you'll memorize it how you do it now, you know what to do, but always keep this in your library so that you'll always, as you go on, if you have to resort back to this, it'll always be there for you, okay? All right. Well, that's a good thing. We got that out the way. Let's look at the lesson plan. All right. All right, specifics, bronchodilators. We left off last time talking about, well, let me make sure wait a minute. Oh, nervous system, I'm sorry. Parts of the nervous system. That's where we got to start today. The 2 parts of the nervous system, and we left off with the dilutions. Yeah, good. We left off with those dilutions. Now, our nervous system has 2 parts. The central nervous system has 2 parts. You have the sympathetic nervous system and you have the parasympathetic nervous system, okay? The sympathetic nervous system or the parasympathetic nervous system, okay? Make this a better color because they are different. You have the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is known as the fight or flight. It's also known as the adrenergic nervous system. All right. So you remember when we talked about I always give you the AKA. Like when we talked about ventilation, we said ventilation, AKA respiratory, AKA acid, AKA CO2, AKA carbia, AKA capnia, right? All of those things mean the same thing, okay? Might have seen them in a different way, but they mean the same thing, okay? So same thing with the sympathetic nervous system. Sympathetic, so I need to write this down. Sympathetic, AKA adrenergic, AKA sympathomimetic, sympathomimetic, all right? Sympathetic nervous system, AKA adrenergic, which is right here, adrenergic, AKA sympathomimetic. All right, it is the fight or flight nervous system. Anything that is a sympathomimetic is, or anything that is a mimetic is something that mimics that, okay? If something is a mimetic, like sympathomimetic, that's something that is trying to copy the effects of that nervous system, okay? A sympathomimetic drug will mimic the effects of the sympathetic nervous system, okay? A sympathomimetic drug will mimic or act like, try to copy the effects of a sympathetic nervous system, okay? So if the sympathetic nervous system gives you bronchodilation, well, then we want a drug that is a sympathomimetic, right? A drug that's going to mimic that and give us bronchodilation, okay? We want a copycat. So a sympathomimetic is something that copycats the effects of the sympathetic nervous system. Everybody understand that? All right. The sympathetic nervous system is also known as the adrenergic nervous system, right? Or the adrenergic response, because what is the root word of adrenergic? What do you think that the root word is of adrenergic?
Adrenaline.
Adrenaline. And that's exactly what it is. Adrenaline. Okay. The sympathetic nervous system, AKA adrenergic, right? AKA sympathomimetic. All of those are the same. And the reason why we say adrenergic is because it's pure adrenaline, right? When adrenaline starts running through the body, these certain things are going to start happening. When adrenaline is released into the system, you're going to have that fight or flight. You know, if you get adrenaline, you can go outside and pick up a car if it's on your baby, right? You ever heard of those stories where somebody said they come outside and the car has rolled over the baby's leg or something like that, and the lady goes out there or the man goes out there and just in the moment of sure adrenaline are able to pick up the car just enough to get their baby out, right? Or jump over a fence if you're running for your life. You just find extra strength and power in your system. That's the sympathetic nervous system that does that, guys. Okay? It's also called the adrenergic. And so when I say adrenergic, I mean like an adrenergic bronchodilator. Albuterol is an adrenergic bronchodilator. It's also a sympathomimetic drug. Okay, you understand that? Albuterol is an adrenergic bronchodilator. It's also called a sympathomimetic drug because it mimics the effects of the what?
Adrenaline.
Adrenaline, or the sympathomimetics mimic the effects of the what?
Sympathetic
Dilators.
Sympathetic nervous system. The sympathetic nervous system, yes, it is going to give you bronchodilation. What I'm trying to get you to be able to link, guys, is the fact that the sympathetic nervous system is the fight or flight nervous system. When your body kicks into fight or flight, that is the sympathetic nervous system stimulation, okay? And so there's other things that happen with the sympathetic nervous system stimulation. We have fight or flight. It dilates the pupils. It dilates the bronchioles, right? And this is what's important right here. It dilates the bronchioles. That's bronchodilation, okay? Bronchodilation. That's what we want. When somebody has an asthma attack, you want to open up their airways, right? When they have an asthma attack, their airways collapse. And I've shown you those little airways models that I have in the classroom. When I show you constriction, I show you normal tone, and I show you dilation. Remember that? Well, when somebody has an asthma attack, their airways collapse, they close. And so what we have to do is give them a drug that will open them back up. And that's called bronchodilation, okay? Well, naturally in life, bronchodilation happens with the stimulation of the sympathetic nervous system. And since I know that, if I'm a chemist or a doctor or somebody who makes a pharmacist or something, I can sit in my lab and say, okay, this person has having problems with his airways closing. And I know that the sympathetic nervous system, when stimulated, will open up his lungs. So let me find a drug or some chemical I can put together that will act like or mimic the effects of the sympathetic nervous system. Aha, albuterol, I found one. So now they give the person albuterol, and it mimics the effects of the sympathetic nervous system and leads to bronchodilation. Okay? Any questions on how that works? Because we got a long way to go. Everybody understand that?
Yeah.
Okay. So the sympathetic nervous system is one part. The sympathetic, aka adrenergic, aka sympathomimetic, right? It uses epinephrine as its neurotransmitter. So in our brains, we have what's called synapse, okay? If you're aware of a synapse, the synapse is the joint between two the neurotransmitter, the neural cell, right, and the brain. And between the cell and the brain, let me turn off my thing so you can see me. Okay, you have the neuron, the neuron, right? And they say this is the brain. The arm is the brain, and my fist and arm is the neuron, right? Well, right there between the neuron and the brain tissue, there's a space there, right? And that space will be called the synaptic clefts, right? The synaptic cleft. That is the space between also known as the synapse. That's the space between the tissue and the neurotransmitter, the neuron, okay? That neuron will send sparks to the tissue, letting it do whatever it's supposed to do. Well, not only that, but between the neuron and the brain, or whatever that is connected to, the sympathetic nervous system uses epinephrine as its neurotransmitter. And that would be the little chemical that comes from the neuron to the brain, or whatever it's connected to, okay? It will drip from there, just kind of like, bleep, 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 right? That's the actual liquid, or the substance that comes from the neuron to the actual nerve or muscle or whatever it's connected to. It uses epinephrine as the one, okay? And the parasympathetic nervous system uses a different neurotransmitter, and you'll find out what that is in a moment. But as for the sympathetic nervous system, it uses epinephrine as its neurotransmitter, okay? In fact, let's see, piece of paper. All right. All right, so this is a rude drawing, but a crude drawing, but it's what I'm trying to understand. This, guys, will be the neuron, okay? And this would be the actual tissue, the muscle, the brain, or whatever that neuron is connected to. This space is called the synapse, okay? The space between the neuron and the tissue. Well, these pieces, this little fluid right here is called a neurotransmitter. The neurotransmitter, which transmits the signal from the neuron to the tissue. It's a neurotransmitter, okay? And you have different types of neurotransmitter. In the sympathetic nervous system, epinephrine is used as the neurotransmitter. And when the epinephrine connects or transmits its signal, it does the effects of the sympathetic nervous system, okay? And we said those effects are bronchodilation, right? What else dilates? What's number 3? I mean, D. Dilates the what?
Pupils.
Pupils. So your pupils open up. You feel fight or flight. You ready to fight or run, right? You fight to the death or run. Guess what else? Your heart rate speeds up and your body starts to secrete adrenaline, okay? All these things are happening when the sympathetic nervous system is activated, okay? So all of this is happening when the sympathetic nervous system is activated. And we don't want all of that, right? When we have a drug, all we want is the bronchodilation, right? But some of the side effects of the albuterol will be heart rate speeds up, dilate the pupils, you start feeling jittery and nervous, right? Those are side effects because albuterol is a sympathomimetic drug. So it's going to affect all of these. It's going to make all this happen. So we have to be careful when we make the drug so we can see which one is stronger in this or stronger in that, okay? And that's where they get to making the big bucks because they can isolate different responses and give the patient the best drug. So you're going to learn what those responses are today. All right, so that's the sympathetic nervous system. Fight or flight causes bronchodilation. That's what we want. So the kind of drugs that we use for respiratory, a lot of the times are specific sympathomimetic or specific adrenergic bronchodilators. Because an adrenergic bronchodilator is something that's going to open up my bronchioles from the sympathetic nervous system side, okay? Because sympathetic is also adrenergic, same thing. All right, second part of the nervous system is the parasympathetic nervous system. Parasympathetic, so here's another list of your AKAs you need to be writing. Parasympathetic, AKA cholinergic, AKA parasympatholytic. All right, so let me write that beside here. Parasympatholytic. Okay, it's parasympatholytic. Well, no, don't write that yet because I don't want to confuse you. The parasympathetic side is the cholinergic side, okay? Parasympathetic, AKA cholinergic. That's what you need to know for parasympathetic because you're going to see this is what we don't want to happen, okay? And so you'll see why I erase that in a minute. So parasympathetic nervous system, guys, is also known as the cholinergic response. What happens during the cholinergic response? Well, that's the feed or breathe, right? We're either going to eat good, we're going to have sex, we just want to relax. Everything is chill, right? That's the parasympathetic nervous system side. The pupils constrict. So sympathetic, the pupils dilate. Parasympathetic, the pupils constrict, okay? The bronchioles constrict during the parasympathetic nervous system response, okay? And the heart rate slows down. So you see it's the opposite of the sympathetic side. And those are two parts of the nervous system that when they pull on each other just enough, they keep us normal. We're not contracted, we're not always dilated. We're right in the middle, right? Our eyes, our pupils are not always dilated. They're not always constricted. They're just in the middle, just kind of like tug of war. Parasympathetic is pulling on one side, sympathetic is pulling on the other side to keep you in the middle, right? To keep us normal, feeling okay. Pupils are normal, heart rate is normal, the bronchioles are normal tone, right? Remember I told you normal tone. And so that's what we want. So they're needed. The parasympathetic is just as important as the sympathetic, right? They're needed to keep us grounded, keep us right in the middle, all right? But when one or the other neurotransmitters kicks up more, then we go into that side, okay? So when epinephrine, it starts to come from the neuron as a neurotransmitter, we jump into the sympathetic nervous system side. When acetylcholine is coming from the neuron, we fall into the parasympathetic nervous system side. So let's see what happens. So you said parasympathetic, AKA cholinergic, okay? Parasympathetic, AKA cholinergic response, okay? I'll put response right here. Cholinergic response. What happens during the cholinergic response? Well, this time the neuron has acetylcholine. So parasympathetic uses acetylcholine as a neurotransmitter, right? So on the parasympathetic side, the neuron uses acetylcholine as its neurotransmitter, okay? This is the neurotransmitter in the synapse. And the parasympathetic nervous system side uses what? Acetylcholine as its neurotransmitter. When acetylcholine is used, they call that the cholinergic response, okay? Cholinergic stimulation or cholinergic response, okay? When acetylcholine is used as the neurotransmitter, then your body will go into the cholinergic response, okay? Cholinergic response. And when that happens, when you go into the cholinergic response, you have pupil constriction, bronchioles constrict, and the heart rate slows down, okay? Everybody understand that? Now, I'm gonna ask some questions so you can tell me which one do we go to. All right, let me see who's all here. All right, Miss Rose, you with me?
Yes.
All right. What happened if what happened or which nervous system causes the heart rate to go up? Just tell me which nervous system.
Sympathetic.
Sympathetic. Okay, good. Miss Scott, which nervous system uses acetylcholine as the neurotransmitter?
Parasympathetic.
Parasympathetic. Good. Miss Woods, which nervous system is the fight or flight?
Sympathetic.
Sympathetic. Okay. Kayla, which nervous system will constrict my pupils?
Parasympathetic.
Parasympathetic. All right. So, and I think Miss Cummings stepped away. Miss Cummings, you feeling better? Okay, she stepped away for a minute. All right. So, good. So, what are some other places in your body that you think need the sympathetic and the parasympathetic nervous system? Think about that. And I'm going to pull up another slide. I want you to tell me what parts of the body you think need the parasympathetic and the sympathetic nervous system to keep it acting or functioning properly. What's some parts of the body you think?
The heart.
Yeah, the heart.
Yeah, the heart, the heart, because it keeps the heart at a right, the sympathetic keeps it up and the parasympathetic slows it down. So, if they're both acting against each other, then it keeps the heart right in the middle. Okay, good. So the heart. Or somewhere else. Let's look at it.
Lungs.
The lungs. So here, look right here. These are all the parts of the body that work off these nervous systems. So look right here. The sympathetic, can y'all see my screen?
Yes.
Okay.
Yes.
Sympathetic nervous system on this side, parasympathetic on this side. All right, this is the brain and spinal cord, right? Brain stem and spinal cord. So the brain stem will be right here, and this is the spinal cord, okay? Notice how the sympathetic nervous system response comes from T1 all the way down to L2. T1 would be the thoracic vertebrae, right, in the chest, mid-back, all the way down to the L, which is the lumbar, around your tailbone. That's where those nerves come from, out of your spine, okay? From your spinal cord, the sympathetic nervous system cords come from this area, all right? And they go to the different parts of the organs. The parasympathetic nervous system comes from the brain stem itself and the sacral part of your vertebrae, which is definitely the tailbone. The thoracic, the lumbar will be right before the tailbone, like the low back, right? The lumbar, the L1 and L2, those are your lumbar spine. And the parasympathetic comes from the brain stem and the sacral nervous vertebrae. So the reason why I want you to see this is look at this right here. What is this right here called?
Reproductive system.
It's part of the reproductive. What is this organ right here called? What is this?
The uterus.
Uterus. So the uterus. Do I need the which nervous system causes the uterus to contract? Think about your systems. Which nervous system would cause your uterus to contract?
Parasympathetic.
Okay. It contracts things. And which nervous system will cause your uterus to dilate?
Sympathetic.
Sympathetic. So you see how they are definitely necessary. If you don't have both of these nervous systems working together, you can't have a baby because you have to have contractions and you have to have dilation, right? What about, let's see, what is this right here called? What is organ right here? What is this part of the body called? What is this? Miss Scott, what is this part right here of your body called?
Is that the duodenum? I can say it right.
The colon. This is the colon.
Colon.
Colon, right? And you know, our feces come from the colon, right?
Yeah.
Okay. So notice how the colon is directed by which nervous system?
The parasympathetic.
Parasympathetic. If you couldn't contract your colon, could you walk around without boo-booing on yourself?
No.
All right. I'm just saying. So that's why that's there. It keeps it constricted so your feces don't just fall out while you're walking. Right? There's feces there. You don't have to sit there and squeeze your butt all day long when you're walking and talking. It does it for you. Okay? There's it's action there in order to allow it to stay closed so that you don't defecate on yourself by just standing there. Okay? But the sympathetic nervous system is doing the same thing, but up here. It dilates the transverse colon, right? This is the transverse part, the one that goes across your stomach. You got the upper, transverse, and lower, right? And then you have your rectum or your colon part down here. And so this will more be your rectum. But up here, your transverse colon, to have stuff move through the digestive tract, it has to open up a little bit. So the sympathetic nervous system will dilate the colon a little bit so that the feces can move. And then when it gets down to the bottom, it stays closed until you are ready to use the bathroom. All right? So that's amazing. It's amazing, guys. Okay, look right here. Sympathetic nervous system touches the pupil. It makes the pupil dilate. And the parasympathetic will make this pupil constrict. Right? Both of them working on the eye at the same time keeps the pupil normal. Right? It keeps the pupil open at normal size. If you didn't have your parasympathetic, then your pupil will always be dilated. okay? It would always be dilated. If you didn't have your sympathetic, then your pupils will always be constricted. They both have to work together to keep the constriction and the dilation in the middle, all right? Another thing, the reason why sometimes when people die or they have a brain injury, they say, okay, the doctor will shine the light in his eyes and they say the pupils are fixed and dilated. That means the patient has no brain activity. Because look, the parasympathetic keeps it down, constricts a little bit to be normal, right? Well, if you get shot in your brain or your brain stem at the lower of your part of your head, this is destroyed now. So now none of your parasympathetic stuff works. Now this stuff down here that works from the lower part may still be working. Your uterus, your kidney, your bladder, your rectum, stuff like that may be working, but none of this works, right? The liver, the stomach, the lungs, the glands, the eyes, none of that, all that's gone when the brain dead. And that's why, because this part of your brain spinal cord has been destroyed. It's destroyed. So when they look at your eyes, your pupils are dilated and fixed. That means they fixed it. They won't go down. Usually when you shine a light in somebody's eyes, the pupil will constrict, right? That lets them know how much are you in there, okay? If they don't constrict when you put light on them, then that means you're gone, all right? And if you have an injury to your brain stem or spinal cord area up here, then you're going to have fixed, dilated pupils because sympathetic is working, right? The sympathetic comes from way down here. So it's got your eyes wide open, but it can't be, checks and balances are not there because you have destroyed the brain stem and spinal cord, okay? So that's why we need both of them on the lungs, right? We need bronchodilation from the sympathetic. See how it's right here in the lungs? That's for bronchodilation. And then we also have constriction, right? We have some constriction to keep it normal tone, okay? To keep it normal tone. All right, so this is a good picture here for that as well. Look how the sympathetic, and like Kayla said, sympathetic and parasympathetic. Oh, hold on one second, guys. Let me pause the recording. All right. So like Kayla was saying, the heart uses both, guys. The heart uses, we got to have it hard because if what can happen? Okay, what would happen? Let's see, who's with me? Miss Rose. What would happen if we didn't have the parasympathetic side of the heart?
It wouldn't be able to constrict.
Wouldn't be able to constrict. You couldn't have contraction, right? We wouldn't have that contraction like we're supposed to have. And then if we didn't have the sympathetic nervous system, like, you know, the sympathetic makes the heart rate go up, right? We wouldn't have that dilation of the valves so they can open and close. All this stuff is working at intricate levels in the body, all throughout the body. This is one nervous system, okay? We have one nervous system that is broken down into two parts. So if we fuse this one and this one together, they're just separating them to show you. You don't have two brain stems, right? You only have one. They're just separated to show you guys where those stimulations are coming from, okay? All right. Okay, so let's keep on going. We'll take a break in a minute. All right, so the parasympathetic, guys, like we said, is also AKA known as the cholinergic response. It uses acetylcholine as its neurotransmitter. It's the feed or breathe. It constricts the pupils, constricts the bronchioles, and slows down the heart. All right. We learned two key terms yesterday or Friday about how drugs act. We have either the agonist or the antagonist, right? An agonist is a drug that goes to the site and causes a reaction. An antagonist is something or a drug that blocks the effect of something, right? So it refuses to give a response. It goes to the nervous, it goes to that receptor and just kind of stands there and blocks it, right? That's an antagonist. All right. So tell me this. If I have a problem, say my cholinergic or acetylcholine is real active in my body, causing the cholinergic response. So Ms. Woods, if my body is having or experiencing cholinergic stimulation, what's happening? Well, tell me one thing that's happening to me.
Your pupils will constrict.
Pupils constricting. What, Ms. Scott, what's something else that happens?
Your heart rate is slowing down.
Slowing down, good. And what's the main thing for respiratory, Ms. Rose?
Constriction of the bronchioles.
The bronchioles are constricting. That's what we mostly concerned about, right? The bronchioles, bronchoconstriction. Okay, well, since we know that, we want to find a drug that will do what, Kayla? If I'm having a cholinergic problem right now, a cholinergic crisis or cholinergic response is happening in my body, I want to take a drug that will do what, Kayla?
Contract your colon.
No, my controller's already contracted if I'm having a cholinergic response. Somebody
Blocks
else?
the stimulation.
Yes, blocks the stimulation. I want something that's going to block the cholinergic response, right? I want an antagonist to acetylcholine. Okay, I need an antagonist to acetylcholine, because if acetylcholine is causing my bronchioles to constrict, then I need to find a drug that will stand in front of it and block acetylcholine. So if I'm having a cholinergic response, I need something that's an anti-cholinergic. Okay, I need a drug that's an anti-cholinergic drug so it will stop that. Okay, everybody understand that? You got me now, Kayla?
Yes.
All right. So if the parasympathetic nervous system is activated, guys, you're going to have these things that you see right here. Okay, this is what's happening. For us, the most important thing is this: constriction of the bronchioles, right? That's what we want. That's what we don't want. I'm sorry. That's what we don't want. So this is what's important. I want to block this. Okay, I want to block this. So I need a medicine that will block the effects of acetylcholine. Okay. Now I'm going to ask you a thinking question. What would be better if I know that a patient has this tendency to have the cholinergic response cause his bronchoconstriction? Then not only am I going to do a parasympathetic, a anti-cholinergic drug, but what else might I give them that will enhance it? What's something else that will give me that potentiation that I need? Remember what potentiation is. What's another drug that what's another type of drug that I could do? Not only an anti-cholinergic, but I would mix it with what, Ms. Scott?
A preventive drug.
A what?
Preventive drug.
Yes. Well, an anti-cholinergic is kind of already in that tone, because it's going to keep your bronchioles from constricting. So that's kind of preventive. But once they constricted, what if they're already constricted? What if somebody comes in with an asthma attack? I'm going to give them this type of drug and that type of drug. What's two drugs I'm going to give them? I need a drug that's
Acetaminophen.
A what?
Acetaminophen.
Listen to me.
Albuterol.
Albuterol, and that will be the sympathetic side, right? So wait a minute. I'm going to give them albuterol, and the albuterol is going to do what to them?
It will give them the it will speed up their heart rate but dilate their bronchioles.
Yeah, I'm not worried about the heart rate. You're right. I'm gonna give them albuterol to dilate that the bronchioles, right? Bronchodilation. Thank you. That's what I'm gonna do. They come into with an asthma attack, immediately I'm gonna give them albuterol to open up, right? Rescue them. I gotta open them up first, and then I'm also gonna give them a drug that's mixed with that will prevent them from closing. See that? So not only am I giving them albuterol, but I'm going to give them an anticholinergic mixed with the albuterol, so that not only am I opening them up, but I'm keeping them from what?
Closing.
That's it. That drug is the drug you're going to be dreaming about. It's called Duoneb. right? It's albuterol and Atrovent. And you're going to learn these terms in a minute. You've already heard about albuterol. Albuterol is an adrenergic bronchodilator, aka a sympathomimetic drug, right? And it opens up the bronchial artery. I mean the bronchioles. Okay, opens them up immediately. It's immediate. It's a rescue drug. The sympathetic nervous system drugs or the adrenergic bronchodilators are all rescue drugs. Okay, the short acting ones are rescue drugs. So somebody come in, I can't breathe, I can't breathe. I'm going to give them albuterol. Okay, and there's some other ones that you can give, but we're just focusing on albuterol right now. We're going to give them albuterol, which is a sympathomimetic drug, also known as an adrenergic bronchodilator. I'm going to give it to them immediately. But not only is it that going to be in the cup, but I'm going to also mix it with an anticholinergic drug. So not only is he going to open up, but now he can't close again, right? So I don't know if the cholinergic is what caused him to close in the first place, but I'm going to open him up first and keep him from closing. That's all medicine is, guys. It's a doctor, and being a doctor, all that is medicine. The pharmacist, a pharmacist with a PhD that you call doctor, whatever, and in pharmaceuticals, they are just as important as a doctor, because that's all we do is give chemicals, right? We mix a chemical, give it to you. We've been doing that since the beginning of time. When we over in Asia and over in Africa and all these different places where they find all these exotic plants that are for medicine, okay? There's some plants up in the mountains of Europe that are medicines that people have cultivated over the years and say, okay, if you eat this leaf and eat that leaf, solves your problem, okay? That's all this is, medicine. And so we sit back and say, okay, let's see what's wrong with the patient and let's come up with a chemical that will fix it. And so if I have an asthma attack, my bronchioles have shut up on me, right? I'm gonna let you take a break here in a second once I explain this. My bronchioles have closed up when I have an asthma attack, right? They're closed. I can't give you an anticholinergic right now to keep you from closing. You don't want that. You need something that's going to open you, right? The anticholinergic drug is not going to open you up. It's not a rescue drug. It just keeps you from closing. But if you're already closed, the anticholinergic can do nothing alone. It needs the albuterol as well, because the albuterol will open you up and that anticholinergic will keep you from closing. So now you stay dilated, all right? And that's what we want as the respiratory therapist. That's potentiation, right? You're adding two drugs that effects are greater when they're together, right? Not only is albuterol good, yes, it's good, and the Atrovent is good, yes, it's good, but the effects are greater when they're together, okay? And so that is, oh, she's joining, okay. So that is what I'm talking about. That is using the sympathetic nervous system side and the parasympathetic at its best. Mixing those two drugs will keep you, open you up and keep you from closing, okay? Now, when we come back from break, we're going to go into some of the specific bronchodilators, right? Not only is albuterol one, but there's several others I'm sure you looked at in your book and saw, okay? There's several other bronchodilators that also open you up immediately. But there are some ticky-tack things we want to look at, because we have what's called receptor sites that can cause unwanted side effects that can be avoided if we pick the right one, okay? And we're going to learn what that is when you come back. I'm going to stop the recording now, take you a... All right, so you just learned that we had one nervous system with two parts. We have the parasympathetic and the sympathetic. You learn the components of both sides. You learn that the sympathetic nervous system gives us the fight or flight or bronchodilation. All right, so I want you to focus on heart rate and dilations, okay? That's where we want to kind of focus. We learned all the things it does, but we're not going to talk a lot about constriction or pupil dilation and all that. We're not going to talk about those things. I want you to now start focusing on the respiratory component, whether it's, and that's the heart and lungs, right? How are these medicines affecting the heart and lungs, all right? And how do they do it? How do they go about stepping on that receptor to cause bronchodilation, right? All right, so we have the adrenergic stimulation. This is the adrenergic stimulation, which is the sympathetic nervous system side, also known as the sympathomimetic stimulation, right? It has 3 receptors. The sympathetic side has 3 receptors that cause all of the action. It's the alpha, beta 1, and beta 2. You gotta know these, okay? Because you're gonna have to know which one of the drugs possesses which receptor and how much, right? Because all of the adrenergic stimulations have these receptors. Now, whether they activate one of them or not is something different, but they all have them, okay? You have the alpha, beta 1, and beta 2 receptors. This is such an uncomfortable chair. Okay, alpha stimulation causes what, Miss Scott?
Vasoconstriction.
Vasoconstriction, good. Those are the vessels. Those are the blood vessels, right? Not the lungs, but the vasoconstriction makes those the blood vessels constrict. Right? The alpha stimulation of the adrenergic stimulation side causes the blood vessels vasoconstriction. Okay, don't confuse that with bronchial constriction. It's not. All right. Look at beta 1, Miss Renfro. What does beta 1 stimulation do? All right, Miss Cummings. You with me, Miss Cummings? All right. Anybody? What's beta 1 cause?
Increase heart rate and the strength of contraction.
Good. Increase heart rate and strength of contraction. So if a medicine has a lot of beta 1, it's going to have a lot of heart effects. See that? That's what that means. If it has a lot of beta 1, it's going to cause a lot of the heart rate going to shoot up, and the strength of it's going to pump harder, okay? Harder and faster, okay? What about beta 2, Miss Woods? What does beta 2 stimulation cause?
Bronchodilation.
Bronchodilation. And this is the one that we want. Beta 2 gives us bronchodilation. That's what we want. So if we're having problems, we want to find a drug that is beta 2 heavy, right? We want to find a sympathetic nervous system drug, because the sympathetic nervous system drugs or the sympathetic nervous system has 3 receptors, period. No other type of drug can touch these receptors. Only the sympathetic nervous system drugs, right? Adrenergic stimulation drugs can touch these 3 receptors. So we know we got to get a sympathetic nervous system drug or an adrenergic drug, right? But we got to try to find one that's beta 2 heavy, because we don't want to have one that'll give you a little bronchodilation but a whole lot of heart effects, right? We want to try to minimize the beta 1 and alpha as possible. Okay, so as we're in our lab trying to figure out a drug, we want that drug to be beta 2 heavy. That's our friend. Beta 2 causes bronchodilation. And if 99.999% of the people that come to you need bronchodilation, right? They're coming to you for respiratory because their lungs need to be opened up, all right? And not only does it help you breathe better, but it helps you clear mucus and secretions. Secretions can't come up if the bronchioles are all closed up. We got to open them up so they can cough that stuff up, okay? So beta 2 is the key. So these are the 3 receptors. Alpha causes vasoconstriction. Beta 1 drugs will cause increased heart rate and strength, and beta 2 will cause bronchodilation. All right. Now, how does this work? How does it work? This is what happens here. Stimulation of the receptors with the sympathomimetic drugs. Remember, those are the drugs that mimic sympathetic nervous system, also known as AKA adrenergic drugs. They cause this. These are the 3 things you have to know of what happens. How does the medicine get from my medicine cup to bronchodilation, right? Do I just breathe it in and all of a sudden I open up? No, there's some things that take place. It's in your book as well. But there's some things that take place. So it's a chain, a domino effect that happen. Number one, when I inhale the drug, okay, when I inhale the sympathomimetic drug, my body it triggers an activation of adenylate cyclase. Okay, adenylate cyclase is activated. That adenylate cyclase will increase the conversion of ATP to cyclic 3,5-AMP. Okay, and the cyclic 3,5-AMP give me bronchodilation. That's the 3 steps. Inhale the drug. After I inhale the drug, now what's important about getting that drug to my system? See, now we see everything's coming back full circle. Not only do I have to inhale the drug, but I have to inhale it correctly to get to my alveoli, right? So that this can happen. If the drug never makes it to my alveoli, then none of this can happen. All right? So what's one thing that's important about getting my drug to my alveoli? Anybody? What's one important factor that determines if my drug makes it to the alveoli?
The size.
Deep breath.
The size of the particle, which size should be what?
1 to 3 microns.
1 to 3 microns. 1 to 3 microns. Okay, what's another factor?
Ventilatory pattern.
Huh?
The ventilatory pattern.
Ventilatory pattern, right? That's important. So I gotta have the correct ventilatory pattern. You gotta be able to teach your patient to breathe correctly, right? So that they can get good penetration and deposition. Make sure I select the right product that will give me the best chance to have therapeutic range in my sizes or my particles, right? All right, so I got good size. I've got good ventilatory pattern, and now the drug gets all the way down into my lungs, all the way down into the parenchyma, okay? Once it gets to the parenchyma, adenylate cyclase that's already in the body is activated, okay? Once it's activated, it changes or converts ATP and turns it into cyclic 3,5-AMP. That gives me bronchodilation. So your number one friend in all of respiratory is this right here, cyclic 3,5-AMP. Cyclic 3,5-AMP gives me bronchodilation. The more of this I have, the more bronchodilation I have. The longer it's in the system, the longer I'm dilated, okay? The more cyclic 3,5-AMP that I have, the more bronchodilation that I can achieve. And the longer it's in the system, the longer I have bronchodilation. It's cut and dry, okay? These are the 3 things that happens once I get that drug where I want it to get, okay? Now, remember I talked about normal tone. I talked about normal tone because you don't want to walk around with your pupils dilated or your lungs dilated all day long, right? We don't want that. We don't want our lungs to be dilated all day long, okay? It's not necessary. We only want to dilate them when we're having a problem, right? And once we get the problem handled, they feel better, we let the body go back to normal. Well, the process of the body going back to normal is called post-stimulation. Post-stimulation. Now, this is what happens during post-stimulation. Once you have breathed in the drug and you have activated that cyclic 3,5-AMP, you have activated your adenylate cyclase. And that adenylate cyclase then converts ATP into cyclic 3,5-AMP. And there we go. Ta, bronchodilation, right? That's what we wanted. Well, then the body also says, okay, bro, we ain't gonna be dilated all day long. We ain't doing this all day. So phosphodiesterase is sitting back watching you dilate. And he or she will say, that's enough, all right? So phosphodiesterase then will come and break down your 3,5-AMP and turn it into 5-AMP. And the breakdown of that cyclic 3,5-AMP will stop bronchodilation. Remember I told you, when you have 3,5-AMP on deck, you have bronchodilation. The more you have, the more dilated you are. The longer it's there, the longer you're dilated. But soon as it starts going away, the bronchodilation goes away. But that's good. That's normal. Phosphodiesterase is not a bad thing. Phosphodiesterase is an enzyme in the body that sits back and watches your bronchodilation. You took in that good old albuterol, that bronchosol, that metoprolol, allopurinol, right? You took in all those isopril, isoproterenol. You took in Zopanex. You took all those, one of those bronchodilators, right? Sympathetic bronchodilator, and cause the adenylate cyclase to activate. It then turns the ATP into 3,5-AMP, and now we are completely dilated. Asthma attack is gone, okay? But you can't stay like that forever. So phosphodiesterase sits back and watches your dilation and says, okay, Miss Cummins, that's enough. Miss Rose, Miss Scott, that's enough, right? It's time to go back to normal, okay? And so what happens is phosphodiesterase will step on the scene and start breaking down your 3,5-AMP. So that's enough. Let's come on down. Come on back down. Come on back in, right? Come on back in. That's enough, right? Like breaking up the fight. That's enough. Pull them away. Break it down. And the breakdown of that 3,5-AMP stops bronchodilation. You go back to normal tone, okay? We need to be at normal tone, okay? Now, I will tell you this. Some doctors don't even want phosphodiesterase to come on deck, right? Because I got bronchodilation. So tell me this, guys, in the chat. Once I have achieved bronchodilation with a massive amount of 3,5-AMP, what is something I can do to prolong that? What is something I can do? What type of drug do you think you could give? And just use your terminology. You don't know specific what they are yet, but just use your common sense terminology to tell me what kind of drug would I need to prolong this 3,5-AMP. Put it in the chat. If you know that after I get 3,5-AMP, phosphodiesterase comes on the scene and starts to break it down because it's saying that's enough, that's long enough. And so it starts to break it down and converts 3,5-AMP into 5-AMP, which will end bronchodilation, which is okay. That's just going back to normal tone. But if I don't want to stop, if I don't want my bronchodilation to stop, I want to prolong the bronchodilation, what type of drug do you think you would have to come up with? Put that in the chat. Okay, Ms. Woods, you already took the adrenergic drug. That's good, but you'll take another drug and start it all over again. I don't want to take another one. So maybe I should have said that. I don't want to take another adrenergic drug because then I run the risk of the beta-1 giving them more of those effects. Without giving another adrenergic drug, what could I do to prolong the bronchodilation? Ms. Scott, I need to be a little more specific. Antagonist to what? Put it in the chat. What could I do? And there's two answers I would take because you might say one or the other. Either one is fine. But I don't want to take another adrenergic drug. After I've taken that adrenergic drug and I got my 3,5-AMP, what can I do? Or what kind of drug can I take that will prolong that? All right. There you go, Miss Scott. There you go, Miss Scott. Miss Rose, look at it again. If I do an antagonist to adrenergic, then I'm going to block myself from even dilating, right? That's called a beta blocker because we know that adrenergic drugs are beta drugs, right? Beta 1, beta 2. But a beta blocker will stop that. So if somebody's taking a beta blocker, then the beta drugs won't even work because they're trying to open you up, but they can't because the patient's already taking a beta blocker. Okay, so an antagonist to adrenergic will be a beta blocker. So that's not what we want to do. Steroid is not what we want to do. Steroids, you're going to learn, Ms. Cummins, are for inflammation. We take those for inflammation. But Ms. Scott, you told her. Ms. Scott said an antagonist to phosphodiesterase, right? An antagonist to phosphodiesterase. If phosphodiesterase is going to come on the scene and break down my 3,5-AMP and stop my dilation, I can block him and keep my dilation. Okay, good, good, very good answer. An antagonist to phosphodiesterase. I'm telling you that phosphodiesterase comes in and says, hey, no more dilation, that's enough. Starts to break down my 3,5-AMP. Well, if I don't want that, I can get a drug that will block him. I can take a drug that will block him as well. That way, when he come on the scene, he can't break down my 3,5-AMP because he's been blocked. Okay? Those type of drugs, which are anti or antagonists to phosphodiesterase drugs, are called xanthines. You're going to learn that a little bit later today. But xanthines are drugs that block phosphodiesterase. Okay? And there's two types of xanthines that you're going to have to memorize. Okay? So I'm trying to show you guys there's categories. We have adrenergic bronchodilators, which have drugs that you got to memorize. Parasympatholytic drugs that you're going to have to memorize. And steroids you're going to have to memorize. The antiprotozoals you're going to have to memorize, right? All these different categories. So you have to first know what category you're dealing with and then what drugs fall into each one. All right. Now, speaking of that, let me go right here. Because I told you that sympathomimetic drugs will mimic the sympathetic nervous system, right? Sympathomimetic drugs mimic, but anything that is a lytic, it blocks. All right. So we don't want a parasympathomimetic because that causes constriction, right? The parasympathetic nervous side, you said, causes constriction, right? Makes the pupils dilate, heart rate drop, and the bronchioles constrict. So we don't want a drug that mimics the parasympathetic side. We want a drug that will block the parasympathetic side, and those are called anticholinergics, also known as parasympatholytics. All right? Parasympatholytic. Now, I told you mimic means copy, but lytic means to block, right? Like a mucolytic. If we're taking a mucolytic, we're trying to block production of mucus. So a parasympatholytic will block the effects of the parasympathetic nervous system, which blocks the cholinergic response. Okay? So there's two drugs. It's only, thank God, there's only two drugs that fall under the parasympatholytic, aka anticholinergic. All right? So go ahead and write your, I don't know if you wrote your AKA down for the parasympathetic stuff, but here it is right here. The drugs that we take for the to block the parasympathetic nervous system side are called anticholinergic, aka parasympatholytic. I'm gonna write that in the chat. To everybody. All right. So parasympatholytic. I don't know if I wrote that down or not. There it is right there. Parasympatholytic drugs, aka anticholinergic. Parasympatholytic, aka anticholinergic. We don't want that response, right? We don't want parasympathetic. We don't want cholinergic because they cause constriction, all right? So if we want to block that, we have to have an anticholinergic drug, or that's also known as a parasympatholytic, because a lytic is something that blocks the effect of it, okay? Just like that mucolytic that we talked about. When we talked about mucolytics and how we're going to stop the secretion, the hypertonic saline and all those different things, to block the mucus or to get it out, right? Those will be mucolytics. And you also have a category in pharmacology called mucolytics, which are drugs you're going to take to actually break down the mucus, okay? Prescriptionally, not bland aerosol, not stuff like that, but actual prescription strength drugs that are mucolytics, okay? Because lytic will block, okay? All right. All right. So if we want post-stimulation, after the stimulation is there, it starts to end because of phosphodiesterase. But if we want to, we can take a drug that will block phosphodiesterase and keep our 3,5 AMP. Okay, good. Now, that was the adrenergic stimulation. That's what happens with adrenergic stimulation. You take an adrenergic bronchodilator, aka sympathomimetic drug, and that's what happens. It's going to hit either the alpha, beta 1, beta 2 receptor. It's going to cause an activation of adenylate cyclase. That adenylate cyclase will then convert ATP to cyclic 3,5 AMP, and you got bronchodilation. After the stimulation is over, phosphodiesterase comes in, breaks down the 3,5 AMP, and turns it into 5 AMP, which ends bronchodilation. That is the story of the adrenergic bronchodilators, okay, that whole adrenergic stimulation. Now, let's look at the cholinergic stimulation, not the anti, but cholinergic. What happens if your acetylcholine starts acting up, right? You already told me, I think Ms. Scott, somebody told me, when acetylcholine start acting up, you're going to have pupil constriction, bronchial constriction, right? Heart rate goes down, all right? And this is how. You have two receptors on this side. There are two cholinergic receptors. One is called the nicotinic, and the other one is muscarinic. Nicotinic or muscarinic. All right? When those two receptors or one of those two receptors are activated, you're going to have the pupil constriction and bronchial constriction, okay, off the nicotinic receptor or the muscarinic receptor. You won't have to know every little thing about both of those, because we're mainly going to focus on the adrenergic one, because that's what we are concerned about, bronchodilation and how we do it, right? But the cholinergic stimulation is, going to cause constriction. The nicotinic receptor says stimulation affects all of the PNS, which is peripheral nervous system, and also affects the sympathetic nervous system and skeletal muscles, causes paralysis of the skeletal muscles, increases production of dopamine, which is the pleasure response. See, remember I said feed or breathe? The parasympathetic nervous system side is the chill side. It's the come on back down. Everybody take it off 10, come on back down, right? But too much of it can cause you to constrict, right? You don't want to constrict, but it causes the feed or breathe. We can go out to dinner, we can watch a movie, we're relaxing, we want to have sex and breathe, right? We want to have kids. It's just a regular chill, relaxing side, right? It causes a release of dopamine. So when the acetylcholine, which is the neurotransmitter of the parasympathetic side, remember I told you the fist and the neuron and the tissue. When acetylcholine is coming down, that causes a chill effect, right? It causes you to it causes a production of dopamine, which is the pleasure response. That's what so many people take pain pills and then take heroin and stuff like that, because it increases the amount of dopamine. That's the high feeling, the feeling good, right? Feeling chill. You can also produce dopamine with exercise. You ever heard of runner's high? People who run miles and miles, when they stop, they feel high, they feel good. That's called a runner's high because of the release of dopamine. That's happening on the cholinergic side, right? Okay. Now that's that's happening on the nicotinic receptor of the cholinergic response. The muscarinic receptors, the stimulation of these receptors stimulates only the PNS. So you won't have to know which one from the other too much on those. Just know that the cholinergic stimulation causes bronchoconstriction. And that's what we want to block, okay? So if we want to block that, we have to have an anticholinergic drug, okay? Any questions on both stimulations? Any questions on the sympathetic nervous system receptors or the cholinergic stimulation? Any questions on that?
No.
Okay. All right. Now let's get with it then. Now we're going to learn lesson 3 talks about some specific bronchodilators. These are bronchodilators that you're going to have to memorize.
I don't hear you.
Son, I'm still working. What do you need?
I need one thing.
What?
A hug. And I want to know why it smells familiar in there.
Dude, I can't have it. No, I
I'm
got some more now.
smelling heat in there.
Heat. The heat is not probably on cold. It's okay. You been messing with anything burning?
No.
All right, we're going and it's
I
coming.
guess it was that green thing.
Okay, the heat is probably on. All right, guys, so the specific bronchodilators. Specific bronchodilators. These are the ones that are on the sympathetic nervous system, aka sympathomimetics. These are all drugs that affect or stimulate or mimic the sympathetic nervous system. Here they are. Number 1, and this is how you need to be making your cards. Your note cards need to be like this. On one side, you need to have isoproterenol. That is the generic name, isoproterenol. On the other side, you need to put trade name isoprel, right? Concentration is a 1 to 200 ratio or a 0.5% solution. Receptor effects. Okay. Isoproterenol, which is trade name isoprel, has 0 alpha, +4 beta 1, and +4 beta 2. It is a short duration, and the dosage is 0.25 to 0.5 milliliters QID or every 4 hours. That is what you need to have on the back side of that card. That way you flash yourself, okay? Isoproterenol, you turn it over, and this is all the stuff that's on it. Because I will ask a question that says, which one of the sympathomimetics has 0 alpha, +4 beta 1, and +4 beta 2, and can be given every 4 hours? You got to know that's isoproterenol. The question and the answer choice might be isoproterenol or it might be isoprel. That's why you got to know both. You got to know everything about these drugs. That's why I said you can't play with pharmacology. Okay? Now, let's look at the receptor effects for isoproterenol. +4 is the high as it goes, right? It goes from 0 to 4, all right? The receptor effects go from 0 to 4. So 4 is the highest, okay? So let's see here. Ms. Rose, do I have good bronchodilation with isoproterenol?
Yes.
Yes, because beta 2 is bronchodilation and it's +4. It's the most as you can get. So I'm going to have excellent bronchodilation with isoproterenol, right? But, Ms. Woods, what else problem am I going to have?
Increased heart rate.
There you go. Beta 1 is heart effects. Look, it's +4. It's the highest you can get in heart effects. So not only am I going to have nice bronchodilation, but my heart is going to be bam, 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 right? My heart going to be jumping out my chest. So you have to be careful because if somebody already has cardiac issues, you can't give them this one because that's going to cause them to go into a problem. All right? Could cause a heart attack, blood pressure, stroke, anything. Blood pressure, all that kind of stuff's going up. So you have to be careful. That's why we don't usually give isoprel anymore. This is an old drug, but it's still out there. Okay? It's still out there. So that's what I want you to be able to see. Okay, I want you to see that, yeah, if I pick that one, he gonna have good bronchodilation, but man, he gonna have a chest pain and heart gonna be jumping at his chest. Okay, good. Next drug, isoethylene. Isoethylene, trade name Bronchosol. Isoethylene is trade name Bronchosol. All right. Concentration is a 1:100 ratio or a 1% solution. Okay, let's look at the receptor effects. Alpha 0, beta 1 plus 1, beta 2 plus 3. Medium duration, dosage is 0.25 to 5 milliliters, 0.5 milliliters with a 1 cc maximum. So Bronchosol has a 1 cc maximum. It has beta plus 1, beta 1 plus 3, beta 2. Okay, now, Ms. Cummings, you with me?
Yes.
Okay. What kind, am I going to have some okay bronchodilation with Bronchosol?
Yes.
Yes, I'm going to have some. It's not going to be the best, right, because it's not 4. It's plus 3, so it's going to be pretty good. And what about beta 1? Am I going to have a whole lot of heart effects with that one?
No, not really.
Not really. I'm going to have a little something, but not too much, right? Okay. All right, so that's a choice. That maybe we could choose that one. But what is ideal? What do you think is ideal, Ms. Rose? Out of the receptor effects, what do you think is ideal, would be perfect?
Talking about like the numbers, the +1 and stuff.
Yes. What would be ideal in a sympathomimetic drug? If you could make one, how would you make the receptor effects be?
Maybe 2 and 2.
Oh, I don't want 2 beta 1. I don't want 2 beta 1. That's heart effects. We don't
Okay,
want
so 0 and 4.
There you go. If it was ideal, we would be 0 and 4. We'll have no heart effects at all. The heart wouldn't feel nothing, right? Whatever your heart doing, this is going to do. It's not going to make my heart rate go up at all. It's not going to make me pump hard or none of that. It's going to have +4 beta 2. So I'm going to have nothing but bronchodilation. That will be ideal, right? That will be, and that's what pharmacists and chemists are trying to do. They're trying to make a drug that will do that. That's why they're doing that with the vaccines and all different drugs that are out there, guys. That's what they're sitting back in the lab testing, trying to find a drug that works better. You know, your drug, like, let's just say, for instance, Miss Rose came out with Isoprel, right? She gave it to her patient. They were giving it to the patients. And yeah, the patients were getting, the asthma attacks were gone, right? But they were all having massive heart issues, right? Heart rate jumped to 120, beating real hard. And like, damn, every time we give them Miss Rose's drug she came up with is pumping in the chest real hard. So somebody said, let me come up with something a little bit better, right? So then Miss Scott came out with isoethylene, which is Bronchosol, right? And it has a little bit less beta 1, not so much heart effects, right? Not so much heart effects, but pretty good beta too, right? Some good bronchodilation. Not as best bronchodilation that we could get, but it's good. It's, 3 is good. That's good bronchodilation and very little heart effects. So that's a better drug, right? So we move on. Somebody else came out with metoprolol sulfate. All right, so let's just say Ms. Woods came out with metoprolol sulfate. Now, this one has 2 trade names, Albuterol and Metoprolol. Metoprolol sulfate is a sympathomimetic drug. That's the generic name. The trade name is Albuterol or Metoprolol. The concentration of that drug is a 5% solution. A 5% solution. All right, so Ms. Woods, your drug is a 5% solution. So how many milligrams are in each cc of your drug?
50
milligrams. Excellent. 50 milligrams for every cc. Good. Okay. So look at the effects of Ms. Woods' drug. She has alpha, none, right? Beta 1 is +2. Beta 2 is +2. Okay, so she kind of fell short with hers, right? Because not only are we going to have some rather strong or medium strength heart issues, but we also only have mediocre bronchodilation, right? So it's +2, +2. So, I mean, you know, if I don't have nothing else, I guess I use that, but I'm not going to pick that one up if I have a choice, because it has mediocre bronchodilation and it has mediate to moderate heart issues, right? That's pretty mediate. +2, I'm gonna have a headache and probably a heart gonna be racing and all of that. So nah, I really don't want to do that one. It's medium duration, 0.2 to 0.3 milliliters TID or QID. Maximum dose is 0.3 ml. The reason why is because it's so strong. It's 50 milligrams for every milliliter, right? So they're telling you you only need to give a person 0.3 mLs of that. And if we wanted to work it out, we could find out how many milligrams that is. That's how you do your drug dose calculation. So if I asked you 0.3 milligrams, 0.3 milliliters of a 5% solution is how many milligrams, right? And you should be able to tell me that. All right, so matter of fact, work that out for me right quick. 0.3, because the maximum dose for metoprolol sulfate is 0.3 mLs. So 0.3 mLs of a 5% solution will be how many milligrams? How many, if I ask you, what is the maximum dose of metoprolol sulfate in milligrams? You have to be able to answer that question, because if you memorize, oh, that's 0.3 mLs, but I might not give you 0.3 mLs. I might give you the choices in milligrams, right? So how many milligrams is 0.3 mLs of a 5% solution? Put it in the chat. That's how some of the answers will come, the choices. You got to be able to work all this out. Good, Miss Woods. Good, Miss Scott. Excellent. Waiting on the other two, and then we'll keep on going. Miss Rose and Miss Cummins. Miss Rose, good. Miss Cummins, a little bit too much, Miss Cummins. Look at it again. You on the right track, it looks like, but you threw something extra in there. Look at it again, Miss Cummins. This math, this your thing, Miss Cummins. .3 mLs of, there you go, Miss Cummins. And good, Kayla. You forgot your suffix though, Kayla. It's milligrams. Don't forget that, because 15 will be incorrect. The answer is 15 milligrams. 15 milligrams. Excellent. So if I asked you, metoprolol sulfate, or I might say metopril, has beta 1 + 2, beta 2 + 2, and its maximum dose is what? And the answer choices were all in milligrams. You know, you got to pick 15, because you ought to already know that metopril is metoprolol sulfate and its concentration is 5%. You got to know everything about these drugs. I'm telling you, you got to. This is pharmacology. But once you learn them, you got them. Okay, once you get to, you got to make these note cards, flashing each other, concentrating, people in your house, studying, and reading in your book, because the Airway Pharmacology is very big in this book. It's nice. It's got a whole lot of information. You're not going to get everything from me. Okay. All right. Next drug. Racemic epinephrine. Racemic epinephrine. Now, it's got 3 trade names, but they're easy to remember. Vaponephrine, micronephrine, and asthmanephrine. If you hear any of those, you know that's racemic epinephrine. Okay. Generic name is racemic epinephrine. Trade name, vaponephrine, micronephrine, and asthmanephrine. Concentration of 2.25% solution. Now, let's look at the receptor effects of this one, Ms. Cummings. What type of bronchodilation, Ms. Cummings, will I have with racemic epinephrine?
+2.
+2, so mediocre. I'm not going to take racemic epinephrine for bronchodilation. I'm more going to use this one. What do you think we're going to use this one for?
Cardiac.
Well, it's going to give me some cardiac issues, yeah. So, but for mainly what? What has this one got that most of them don't? The other ones don't even have.
The alpha.
Alpha. So racemic epinephrine is more used for its alpha effects, which is what happens when we stimulate the alpha, Ms. Woods?
Bronchoconstriction.
No, alpha.
Vascular.
There's no. Not bronchoconstriction. There you go. Vasoconstriction. Vasoconstriction. So this is what we give when somebody's throat swells up from bee stings, or they ate some shellfish and they weren't supposed to, or they're allergic to bananas, allergic to dogs, dander, all kind of stuff, and they have an allergic reaction, anaphylaxis, right? When the tongue and the throat start to swell up because of an allergic reaction, you need racemic epinephrine. Because of its alpha effects, it's going to shrink the vessels and make the throat open back up. Because those vessels have swollen up, right? They're swelling up in an asthma, not asthma, but an allergic reaction. Those vessels in the throat, the tissues have swollen up. And so we need vasoconstriction to bring those vessels back down. Those blood vessels shrink and open the throat back up. So you ever heard of an EpiPen? When somebody has an EpiPen, a child has an EpiPen for whatever reason, they have it at their school or they always have it in their backpack because if they're outside, they're allergic to bees, they got stung by a bee and their eyes swell up, tongue, throat starts swelling up and they can't breathe. You have to stick them in the leg with that EpiPen and immediately releases an epinephrine into the system. And the epinephrine has a very large alpha response, okay? Epinephrine will give you vasoconstriction and make that throat go down so you can get them breathing and take them to the hospital, okay? That's why we use racemic epinephrine. So, oh, okay, allergic to milk. So yeah, he has an EpiPen. So if something happens, he's gonna use either an EpiPen or just take a breathing treatment called racemic epinephrine. Racemic epinephrine is a breathing treatment, right, that we can give them that will give them alpha. So yeah, you're gonna have not only alpha, but their heart rate gonna jump up too, because it's gonna cause the heart rate and strength to go up and have vasoconstriction. Now, bronchodilation, a little bit. We wouldn't pick this one just for bronchodilation. If they don't have an allergic situation, I'm not even reaching for epinephrine, okay? What's another reason why my throat may swell up? What's something else we talked about that causes stridor?
Sputum.
Huh?
Sputum.
Sputum? No, not sputum. Something else that would cause stridor.
Intubation.
All right, guys, if you said something, I didn't hear you because I stepped away to get this medicine, my medicine for you. Over the years, you'll learn that you're amass your own little hospital at your own house. Don't
Is it
tell nobody.
intubation?
Extubation, yeah, extubation. Once I take the extubation is when we take the tube out, right? So we take the tube out, yeah, sometimes we're gonna have the throat swell up on us. And when that happens, if the bland, cool water aerosol does not work, then we can just give some racemic epinephrine and open them on up, okay? All right, the reason why I got this right quick is I want to show you a couple of things. Trash in here. Just kind of show you the breathing treatment stuff. A few things, and then how it may come as far as dosages is concerned. All right, first we're going to look at let's look at racemic epinephrine. Racemic epinephrine. See that? This is a breathing treatment. You open it up and it's in a little vial, right? I just break the top and squirt it into my medicine cup. But this is racemic epinephrine. For inhalation only, see, for inhalation only, it is a 2.25% solution. Okay? All right, let's look at this one. This one is, somebody tell me what are the two medicines in this one? What are the two medicines you see? Albuterol and
Something bromide.
ipratropium bromide. Ipratropium bromide or ipratropium bromide is also known as Atrovent, and that's the anticholinergic drug that we take for blocking acetylcholine. The drug that we take to block acetylcholine is called an anticholinergic. The one that we use is Atrovent, which is the trade name, and ipratropium bromide is the generic name. But you're going to learn that now. You don't have to memorize it this second. You're going to see it shortly. Okay, but I told you, if we put both of them together, the albuterol will open them up, and the ipratropium bromide can keep them from constricting. All right? All in one medicine called a duo neb. Two medicines already mixed in one. So I got several of these. So I'll open this one. So I'll open this one up. And it's a little vial, right? 3 mLs worth of medicine. Okay? I will pop the top. You will just simply twist the top off like that. And squirt it into your medicine cup. I'm not going to drink that, but squirt it into your medicine cup. Turn on the nebulizer. There you go. They are getting albuterol and they're getting Atrovent. The albuterol is working by activating the adenylate cyclase, which converts ATP into what?
Cyclic,
Cyclic
3,5.
3,5-AMP, cyclic 3,5-AMP, and that cyclic 3,5-AMP causes
Bronchodilation.
bronchodilation. And the other medicine that happens to be in there today, in that dose, is Atrovent, which will keep you from closing because it's an
Allergic.
There you go. Anticholinergic. Miss Scott, you got this down pat. All right. Now, this one here, what's this one called? This say
Bravana.
Brovana. It's a steroid. You're going to learn what that is in a little while. That's another duo neb. What about this one? What's this one say?
Albuterol.
Levalbuterol. Levalbuterol, guys, you're going to learn here really quickly, is a isomer of albuterol. Albuterol, also known as Xopenex, is no beta 1, no alpha, and +4 beta 2. This drug is extremely expensive. This is about $400 a treatment. This vial in my hand right here is about $400. Albuterol is about $200. If I go into a breathing treatment, if I'm looking at the charges, that's about $220 to give you an albuterol treatment. But if I give you a albuterol treatment, it's about $400 because it's such a formulated drug, right? They have to really spend a lot of money to make it because it has no beta 1, no alpha, and mostly just 4 beta 2. It's a beta 2 agonist only, and that's why everybody wants it, okay? But you have to have issues in order for me to switch from albuterol to this, and that's somebody who has tachycardia already, right? If somebody's heart rate is already 120 and they need a breathing treatment, don't give them albuterol, or see if you can switch the albuterol to Xopenex, which is albuterol, because albuterol want to make the heart rate go up even more. You're going to see in a minute what they are for albuterol. All right, and the last thing I'm going to show you is this one. This one is called, this is not acetylcholine, this is acetylcysteine. Acetylcysteine. This is a mucolytic, also known as mucomist. Mucomist. Okay? Acetylcysteine is known as mucomist, and it is a mucolytic. It breaks down mucus. Okay? All right. All right, it is 10:04. Let's just say it's 10:05. Let's take a break till 10:15. 10:15, and we will go on to the rest of the lesson plan. After the break, we're going to go into the rest of the short-acting bronchodilators after the break. Pause the recording because we just did racemic epinephrine. When we come back from that, we're going to do regular epinephrine. Regular epinephrine. And this is not for inhalation. This drug here is for IV. Okay, hold on one second. Come back at 10:15. Back from break. Continuing on with those specific bronchodilators. Okay. I showed you earlier the albuterol and the Atrovent together, and I just want to quickly show you them separate. Sometimes we don't give them together. Sometimes the doctor will just give albuterol only, right? This albuterol comes in a 0.083% solution. Okay. All right, so that's albuterol by itself. And then sometimes we give Atrovent or ipratropium bromide by itself. Ipratropium bromide, it's always the green one, is Atrovent or ipratropium bromide by itself. And the blue one is always albuterol by itself. And then the purple and, I think it's purple, yeah, blue and purple is always the duonel. So it's easy to kind of, you're picking it up, it's easier to look at. And make sure, remember we say always make sure that the medicine is in date. So look at this one. When is the expiration date of this one? When is the expiration date of this one?
September the 19th.
September 2019. So that one's old, right? This is old stuff I have just to show. Okay, but I mean, guess what? If I had to use it, I would. All right. In my box of medicines. All right. We even have albuterol for babies. See that?
So will it have a different effect if it's out of date? Like, will it not have the same effect?
I don't know. It don't spoil, and as long as it's in, not in the light and it's put up, I don't think so. I just think they just want you to, bureaucracy to make sure. It probably can lose a little bit of its half-life over a long time. Maybe like if it was 2026 and it expired in 2019, that, it might be, but 1 year away, no.
Okay.
Yeah, no, I wouldn't worry about it. All right, so as we continue, the other sympathomometics, we have done isoproterenol, which is isopril, isoethylene, which is bronchosol. We talked about metoproterenol sulfate, which is both alupent and metopril. We talked about racemic epinephrine. It is the inhalation epinephrine, okay? We give it for those effects like allergic reactions, okay, or stridor because of extubation, anything like that. We can give racemic epinephrine, okay? The dosage of it is, duration is about 1 to 1.5 hours. Dosage is 0.25 to 0.5 milliliters every 1 to 2 hours. Do it as much as you need it, okay? And then now we're at epinephrine HCl. Now epinephrine, this here, guys, is a mostly a IV. This is a sympathomimetic drug that's an IV, okay? Trade name, adrenaline. Epinephrine HCl is liquid adrenaline, okay? Liquid adrenaline. Now look at the receptor effects. Alpha +3, that's giving us vasoconstriction. Beta 1 +4, massive heart effects. And beta 2 +3. So not only is the liquid epinephrine going to give me massive vasoconstriction and massive beta 1, which is heart effects, strength and heart rate, it's also going to give me a fair amount of, a moderate amount of bronchodilation, but I'm not going to take it for that. We're taking liquid adrenaline or epinephrine HCl for people who are about to die, okay? Somebody, for instance, regular blood pressure is 120/80, right? If you have somebody whose blood pressure is 75/30, they are about to die, okay? So you have to get their blood pressure up. And so the way to get the pressure up is to decrease the vessels. What happens when I put my thumb over the water hose? What happens to the blood inside of there or water inside of there?
It increases.
It increases the pressure, right? The pressure increases because I decrease half of the diameter. Whose law is that? Whose law says I decrease the diameter by half, I will increase the resistance by 16 times? Whose law was that?
Henderson-Hasselbalch.
No, that's pH. Henderson-Hasselbalch is not a law. Henderson-Hasselbalch is just a formula to find pH. Whose law talks about resistance?
Or Posey.
Poisson. There you go. Poisson. Poisson says that if you decrease the diameter by half, you increase the resistance by 16 times. Well, if somebody is about to die, their blood pressure, they're experiencing hypotension, their blood pressure is dropping. This is when you put them on epinephrine drip. Okay, this person is on an epinephrine drip, also known as Levofed. All right. The trade name is adrenaline, but you may also see Levofed. When you get in the hospital, Levofed is what we use in the hospital. Hello? Levofed. And what we usually say to remember that, Levofed, leave them dead. That's how we remember. If somebody's about to die, we put them on Levofed, okay? Which is liquid adrenaline or liquid is epinephrine, okay? And that's going to give them vasoconstriction, which will increase the pressure of the blood in the vessels, which will increase the blood pressure, okay? It's going to increase the blood pressure. The beta 1 will also speed up the heart rate, right? And make it pump harder because the heart is starting to become bradycardic, right? It's going down. It's pumping real weak. The patient is dying. If there's no pressure in there, everything is weak, right? The patient is actively dying, okay? And for that, or if they have blood loss or something like that, their pressure going to drop. So we can give them, or the nurses will give them IV epinephrine, all right? This is not for bronchodilation. This is simply to keep the patient alive. All right, this is liquid adrenaline. It's short duration. That's why they have to usually use it on an IV drip, okay? Dosage is 0.2 to 0.5 milliliters every 2 to 4 hours.
What?
Mute your mics, guys. If you're not answering the question, mute your mic. All right, there we go. All right. The next one. Oh, let's finish this one. Trade name is adrenaline. Receptor fights alpha +3, beta 1 +4, and beta 2 +3. All right. Concentration 1 to 100 ratio, or 1% solution. Short duration, and I just told you the dosage. That's epinephrine. Now, epinephrine is different from racemic epinephrine. It's not the same thing. Racemic epinephrine doesn't have as strong as a beta alpha that epinephrine has, okay? And this is the one with the racemic epinephrine, is the ones we use for breathing treatment, okay? The vaponephrine, micronephrine, and asthmanephrine, right? Those are the ones we use for breathing treatments. Epinephrine is more like an IV, okay? These will be more of an IV med that will give to help keep the blood pressure up and the heart rate and everything up, okay? All right. The one that everybody knows, salbutamol, aka albuterol. Now, the reason why we say it is because albuterol is the generic name in the United States. Okay? Internationally, albuterol is known as salbutamol. All right? Just like the green tank in America is oxygen, everywhere else in the world, oxygen is white. Well, in America, albuterol is called albuterol, but in Europe or anywhere else in the world, it's called salbutamol. So both of those are generic names, okay? This is the American generic and the international generic, okay? The trade names of these are Ventolin and Proventil. Ventolin or Proventil is the trade name for albuterol. Now, let's look at the receptor effects of albuterol. This is why everybody uses albuterol so much. No alpha, beta 1 is just +1, and beta 2 +4. So with albuterol, we're getting massive amounts of bronchodilation and just a little bit of heart effects and no vasoconstriction. So this is why people use it. Albuterol is so popular and so common to the ear because everybody uses it. You can pretty much talk to anybody and say, have you ever heard of albuterol? They're gonna say, yeah, ain't that something that you breathe, right? They even if they don't know anything about medical, they know albuterol is something you breathe, okay? Because it's so widespread use, right? It's used everywhere for asthma, okay? But it does have some beta 1, right? So that means not only are we going to get massive amounts of bronchodilation, but we're still going to get that nagging beta 1 effect. We're still going to have a little bit of heart may go up a little bit. You know what I'm saying? Like if their heart rate is already 110, 115, you might not want to give them albuterol. Sometimes the doctor will only give them the Atrovent, or they may even go into the Xopenex, right? So instead of the Duonair, where I'm getting ipratropium bromide, which is the Atrovent, mixed with the albuterol, sometimes they'll just give them the Atrovent only because they have heart effects, and that'd be something they give every 4 hours or whatever, and you know, to keep you from having an asthma attack, because we know that the anticholinergic drug, which is Atrovent, also known as ipratropium bromide, keeps you from constricting. All right, so if you haven't been constricted yet, but we're giving it to you, you know, every 4 hours routine, we can give you that to keep you from having the asthma attack, right? So you don't have to have the albuterol every time, but we usually give it to you in conjunction, okay? Just give them to them together. But don't forget, the rescue drug is albuterol. Atrovent or anticholinergic is not going to open you up. It just keeps you from constricting, all right? If I am already constricted, then I need adrenergic bronchodilator to open me up, okay? then I can mix the other one in there to keep me from closing. We can do all kind of stuff then. We can take albuterol and atropine. We can take an phosphodiesterase drug, right? We can do all this in one drug or 3 or 4 drugs to do all this different stuff in the system. And that's what you're going to see. Your patients are going to be on several medicines. They're going to be on an anti-cholinergic drug. They may be on a bronchodilator. They may be on a steroid. They may be on an antibiotic breathing treatment, all kind of medicines that your patients may be on, okay? And just throw medicine at them. So albuterol, these are the receptor effects for albuterol. So when you're making your cards, I recommend generic name on one side, then on the other side have the trade names, the strength, and the receptors, right? The duration and dosage, all that stuff on the other side, okay? That's gonna help you memorize this stuff. All right. Couple more. Terbutaline sulfate. Terbutaline sulfate is another specific sympathomimetic drug or adrenergic bronchodilator from the list that you have to memorize. Terbutaline sulfate is the generic name for Bricanal or Brethine. Bricanal or Brethine, right? 2 trade names for terbutaline sulfate. What are the receptor effects of terbutaline? No alpha, +1 beta-1, and +3 beta-2. So it's close to albuterol. Terbutaline sulfate is pretty close to albuterol, it just has a little less bronchodilation. Albuterol is 1 in 4, and terbutaline is 1 in 3. Concentration, look at this one. The concentration of that one is 200 unit grams per puff. Per puff. So this one is not an aerosol. This one's an MDI, the little pumper, right? This is for the little pumper here. This medicine is given as a MDI, which is a metered dose inhaler, right? Metered dose inhaler. We got to also have a PowerPoint that goes over all of the delivery ways, the delivery devices. Should probably go over that on tomorrow in the classroom. Now, there's no 100% that I'm going to be in the classroom tomorrow. I may be just like this again tomorrow, but look for your announcements this evening or tonight to know for sure, okay? Long duration, the dosage is 2 puffs every 4 to 6 hours. Terbutaline sulfate, Bricanal or Brethine, right? It comes as an MDI at 200 unit grams per puff. And the dosage is 2 puffs every 4 to 6 hours. So how many unit grams are given at a normal dosage? How many unit grams of medicine will a patient get in one dose? How many unit grams will a patient get in one dose?
400.
400, because it's 2 puffs, and each puff is 200 unit grams. So the dosage is 2 puffs every 4 to 6 hours. So when you squirt them 2 times, they're getting 400 unit grams of medicine. Okay? All right. Finally, last one, lev-albuterol. That's the one I showed you earlier. Lev-albuterol. This is the one that's very, very expensive. Trade name, Xopenex. Starts with an X. Xopenex, not a Z. Xopenex is the trade name for lev-albuterol. It is an isomer of albuterol, just a little isomer. Very specific beta-2 agonist. No alpha and almost no beta-1 at all. It's pure beta-2. Pure beta-2. Lev-albuterol is pure beta-2. So this person will not have any heart effects with this medicine. It will only give them bronchodilation. Now, lev-albuterol comes in 2 strengths. All right, comes in 2 strengths. It comes as 0.63 milligrams every 6 to 8 hours, or 1.25 milligrams 3 times a day. And it lasts pretty long. That's why it's so expensive. You don't have to give it every 4 hours. You can give this one 3 times a day, or you can give them every 6 to 8 hours. That's what you want right there. But it costs so much that they usually just do albuterol. okay, unless the person has a heart effect that you can't give them albuterol, okay? So this one here, this Xopenex, what is the strength of this Xopenex?
1.25 milligrams.
1.25 milligrams per every half a cc, right? So what it's saying, for half a cc, you're going to get 1.25 milligrams for half a cc. So what's the concentration of the solution then? If you think about it, if there's 1.2 milligrams for every half a cc, then how much is it? How much is the concentration really? So we said milligrams over 1 cc is the concentration. So if this is telling us 1.2 milligrams for half a cc, then how many milligrams is it for 1 cc? And that will be the total concentration.
Is it 1.25?
It's 1.25 for every half a cc. Concentration is milligrams over 1 cc, remember? So what would this be for 1 cc? If I give them a whole cc, what is the concentration?
2.5.
0.5 milligrams. 2.5. So if it's 2.5 milligrams, then what is the percent? What is the percent solution of it? If it's 2.5 milligrams per every cc, then what would the percentage be?
0.25.
0.25. Excellent. This is 0.25%. This is a 0.25% solution because 0.25 is 2.5 milligrams for every cc, and that's half of this, right? So this is saying 1.25 for every half a cc, and we know that 1 cc is how you find out the concentration, right? Concentration over 1, right? So they're telling you 1.25 for every half a cc. So if it was a whole cc of it, it would be 2.5 milligrams, which would be 0.25%. That's why I gave you that, Ms. McCarthy's drug dose calculations trick. Make sure you practice it now. See, this one even says dilute before use. So how much do you think we would dilute this with? Just guessing. Since this is only in a half a cc, how much do you think we would dilute it for?
1/2.
Another half. Probably just put another half cc, and that way we got a whole cc of solution. Okay, so they're just saying dilute it before you use it. So this is the 1.25 milligram Xopenex. And this one is, let me see what this one is. Might be hard to see this one. What is this one? What is this one?
0.63.
0.63. 0.63. So Xopenex comes in 2 strengths, right? Xopenex comes into 2 strengths, what I just showed you. 1.25 and 0.63. There it is right here. Dosage of Xopenex. 0.63 or 1.25. The 1.25, you give that 3 times a day. How many hours is that? If it's just 3 times a day, how many hours is in between each one?
8.
8 hours, no less than 8 hours. If I give the 0.63, I can give that 6 to 8 hours, right? Every 6 to 8 hours. Good. That's how you're using everything you've learned as we move on. So you can't just forget that stuff you've learned. All right, what are the side effects of adrenergic bronchodilators? Well, we have cardiac and we have systemic side effects, okay? So all of the red ones are going to be cardiac, all right? So palpitations, right? tachycardia, hypertension, that's high blood pressure. All right, let me see. All right, those are all of these three here are the cardiac side effects. The rest of these guys will be systemic side effects. Restlessness, right? Restlessness. Let me change that color to, let's say, let's do green. Restlessness, fear, anxiety, tremors. Somebody kind of got the shakes. They're shaking a little bit. Weakness, dizziness, and pallor. Pallor means you kind of turn pale, clammy. And think about it. If you just had a fight or flight response, when you about to fight somebody, don't you be kind of, aren't you kind of jittery or nervous, anxiety? Your hands might be shaking a little bit because you're so mad. Like you ball your fist up and your fist kind of twitch a little bit, shake a little bit. Have you noticed that before? When somebody is close to death, or they just saw some death, or somebody in the family just died in their face, and they're just worked up, right? And they just kind of shaking, okay? Not like shaking hard, like shivering, but just hands just a little shaky because they're so excited. They're so worked up. That is the sympathetic nervous system, guys. These medicines are on the sympathetic nervous system side. So not only are they giving you the palpitations and the tachycardia and hypertension they could possibly do, but they also give you fear, anxiety, tremors, weakness. You might even get a little dizzy because you're so nervous. That is the fight or flight system, all right? So these green ones are systematic side effects, and cardiac side effects will be these three. You will have questions say, what name, all of these are cardiac side effects except, right? You need to know the cardiac side effects are just those first three. Palpitations, when the heart just says boom, 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 all of a sudden just flutters. You're like, what is that? That's palpitations, when the heart just beats real fast for a minute and it stops. Tachycardia is just consistently high heart rate greater than 100. So you might have had, your patient may have had a heart rate of about 85 or whatever. Nice, everybody's calm. You give them albuterol and it shoots to like 110. That's a side effect. We don't want that, right? We might say, hey, you shouldn't have went up that high. Let's think about something else. Hypertension, which means the blood pressure shot up, okay? So you have to be mindful of your side effects and which ones are which. The rest of them are just systemic, right? Just things that happen throughout the body from the reaction of the adrenergic system, okay? All right, you save that, make sure that's all this is being saved, and I'm writing. All right. Now, these drugs are the specific sympathomimetics. Specific. These are the ones we're going to use the most. The specific ones that you got to memorize. Isoproterenol, isoethylene, metaproterenol sulfate, racemic epinephrine, epinephrine, salbutamol, which is albuterol, and terbutaline sulfate, and finally levalbuterol, which is Xopenex. And these are the side effects. Now, that's the front door. That is the front door. I go into the, if I'm looking for bronchodilation or I'm causing bronchodilation, I go straight through the front door and cause it. I've already given you, you already know how it works. Activation of the adenylate cyclase converts ATP to cyclic 3,5-AMP, and you have dilation. All of these drugs do that, okay? Whether they do, one does more than the other one, but they all do it, okay? That's the front door. Now, there's some other ways we can come about bronchodilation as well, and not in the front door. There's a side door or a back door or through the window, right? Other ways to get to achieve bronchodilation, right? The first way is xanthines. Let's see who's in here. Xanthines. Miss Woods, tell me what xanthines do.
It inhibits Desterase thus maintaining levels of cyclic AMP.
Good. Cyclic 3,5 AMP. Don't forget that because there's a difference between 3,5 and 5. All right. So xanthines are the drugs that are anti-phosphodiesterase drugs. What you guys told me earlier, that if I want to block phosphodiesterase from breaking down my cyclic 3,5 AMP, right, and ending my bronchodilation, I can block him if I want to, right? And the way I block him is through xanthines, drugs called xanthines. All right, now what are those drugs? Xanthine drugs are theophylline, and aminophylline. Okay, theophylline and aminophylline are the two xanthines. There are only two xanthines that we use, and that is theophylline and aminophylline. Aminophylline, or whatever you want to say. Xanthines are the drugs that block phosphodiesterase. And remember, we said phosphodiesterase comes on the scene after bronchodilation, right? After we have good old bronchodilation, the body says, all right, that's enough, come on back in. We're going to break that 3,5 AMP down to 5 and go back to normal tone. But if the doctor says, no, I don't want to go back to normal tone, I want that patient to stay dilated. Once they dilated, I want them to stay dilated. Well, then that means I got to find a drug that's going to be an antagonist of phosphodiesterase. And that is a drug that will block phosphodiesterase, and they are called xanthines. Sometimes they're called methoxanthines, okay? You may see that. You may see methoxanthines. So let me put a little slash, put methoxanthines, okay? You may see that. Xanthines or methoxanthines. I think that's how you spell it, but you'll know when you see it. They block phosphodiesterase, and there's only two drugs that block or phosphodiesterase. There's only two xanthines, and those are theophylline and aminophylline. So what you need to know about them is, well, theophylline is available only in tablet or syrup. Okay, elixir is a syrup. Okay, that's theophylline is either in a tablet or pill, a pill or syrup. All right, aminophylline is given IV or in a pill. Okay, but this is how it works. There's a loading dose involved. We give you a massive amount of it first, and then we check your blood levels to see if your level of xanthine is still 10 to 20 milligrams per deciliter of blood. Okay, we give you a loading dose, and then we check you every now and then to see if that therapeutic level is still in there. Okay, so there needs to be a level of at least 10 to 20. When I test your blood, if I want phosphodiesterase to stay off the scene, then I have to keep at least 10 to 20 milligrams per deciliter of xanthines in the blood. That's the only thing that's going to keep him off your back. Okay, the only amount to keep phosphodiesterase at bay. I have to have at least 10 to 20 milligrams per deciliter of xanthines, whether it be theophylline or aminophylline, whichever one I'm taking. I got to make sure the amount in my system is at least 10 to 20 milligrams per deciliter at any given time. Okay, so what we do is we give you a nice amount first. Okay, give you a nice amount of it, and then maybe an hour later, 2 hours later, we get a blood from you and see if we can still see the xanthines in the blood, and their level needs to be 10 to 20 milligrams per liter. If that level falls below 10, guys, then phosphodiesterase starts coming back. All right, we want to keep him at bay. So the only way you're going to keep him at bay is to constantly put the xanthine in the blood. So it's like somebody trying to come in your house, and the door doesn't lock. You just have to stand there and hold it. Well, there's a certain amount of pressure you got to hold on the door to keep him out. If you let off that pressure, he coming back in, okay? But as long as you holding that pressure, he can't come in. So that's what we're doing with the theophylline or the aminophylline, which are xanthines. The only way to keep phosphodiesterase out is to apply at least 10 to 20 milligrams per deciliter in the blood. Keep hitting them with it, all right? As soon as I stop giving it to them and the levels fall below 10, then phosphodiesterase then can start to come back in again, all right? Now, that's how we do therapeutic serum level. That's what it says, therapeutic serum level. That's the level in the blood, right? So if I get Miss Woods and I gave her theophylline about 2 hours ago, if I get a blood check on her, I'm looking to see if her levels are still 10 to 20. If they're not, I need to give her some more. If they are, I leave her alone, okay? All right, what are the side effects of methoxanthines? The side effects are dizziness, headache, restlessness. They can even give you palpitations, tachycardia, nausea, vomiting, and anorexia. Because if you're some people that take xanthines are always nauseated, right? So if you're always nauseated, then you're not going to eat, okay? And it could be if you have so bad of an asthma problem or so bad of a lung disease where you constantly need to be dilated, then you're eventually going to start losing weight because you're never going to eat because it causes you to be nauseous. Every time you eat, you throw it back up, okay? So those are some of the side effects of xanthines, okay? Xanthines. Now, 6 just says many doctors now disregard this agent as a choice to treat asthma, right? You used to use xanthines to treat asthma. So they say, well, we don't, asthma is going to cause their lungs to bronchospasm. Well, we can not only give them the anticholinergic to keep them from constricting, but we can also give them theophylline or aminophylline all the time, just as a prophylactic to asthma, right? So we don't want them to have no asthma attack at all, but they stopped doing that because it has such bad side effects, okay? Don't worry about this subcutaneous thing right here because we're not going to deal with that. All right, parasympatholytic or anticholinergic drugs. I told you that, and you explained to me that a drug that blocks acetylcholine is a parasympatholytic drug, or also known as a anticholinergic. That's what you said. If I said, what kind of drug will keep you from constricting, or a drug that would keep my pupils from dilating? That would be a anticholinergic, right? Okay, so what drugs fall under that category? Here we go. Atrovent. Atrovent, which is the trade name for ipratropium bromide. Atrovent is the trade name for ipratropium bromide. All right, where's my Atrovent? Here we go. Atrovent is the trade name for ipratropium bromide. It is a anticholinergic drug. It works by blocking the effects of acetylcholine. All right, here it is. Ipratropium bromide. It's also known as Atrovent. That's this right here, all alone. Okay, this right here is an anticholinergic drug. Okay, that will keep your lungs from constricting because of acetylcholine. So if acetylcholine is causing your constriction, we give you something to block acetylcholine, and it's an anticholinergic. Okay. All right. Now, there is a contraindication for ipratropium bromide. The main one is if you're allergic to soybeans or peanuts. If somebody has an allergy to soybeans or peanuts, you cannot give them Atrovent. You cannot give them an anticholinergic drug, okay? If you do that, they're going to have an allergic reaction, okay? And then you're going to be looking for your racemic epinephrine or your EpiPen to take care of them. So, but Mr. McCarthy, how are we supposed to know that? Every chart, when you go into a patient's chart, at the top of their name, it's going to have what allergies they have. If they have no allergies, it's going to say NKA, no known allergies. NKA, no known allergies. If they have that, then they don't have no allergies, or they never said that's what they have an allergy for. You can't guess. Okay, but if you look at their allergy list and it says peanuts, oh, that's a good catch. They're gonna say, oh yeah, the doctor may say give them Duonil. They ain't even thinking about it. But when you look at the allergy and say, doc, we can't do Atrovent because he has a peanut allergy. You say, oh, the doctor's gonna say, great catch, because I didn't see that. We can potentially kill them. We're giving them Atrovent. Okay, so you look at that and say, no, I can't give that. So you ask the doctor. That's one of those things. The patient has a peanut allergy, and then they'll throw that in there, right? And then they'll say the heart rate was this, ABG is this, blood work is all this, patient short of breath, doctor recommends Duonil. And you already done got caught up with all the other stuff. Oh yeah, I got the ABG, I know what this is, I know what that is, right? And you forget about that peanut allergy. And if you say, yeah, I agree, you killed the patient. No, you don't agree, doc. This is the ABG stuff, and I got all this down pat, but this patient has a peanut allergy, so we cannot give them Atrovent. And that will be the correct answer, okay? Now, what happens is it blocks the production of cGMP, because cGMP is what causes the constriction, okay? cGMP causes bronchial constriction. And so we need something that's going to block that. So anticholinergic drugs will block the production of that, which keeps you from constricting. All right. What are some of the side effects? Once I do decide to give it, the main side effect is a dry mouth. Anticholinergics will dry your mouth out. Anticholinergics will usually dry the patient's mouth out. A dry mouth. My mouth's so dry. That's why. Okay, that's why, because of the Atrovent. And it's used often in conjunction with albuterol, right, as a Duonil, because it enhances the bronchodilation. Because albuterol is going to bronchodilate them, but the Atrovent is going to block the cGMP, which keeps them from constricting. Now, phosphodiesterase and cholinergic is two different things. Cholinergic response makes you constrict. Phosphodiesterase only takes you away from dilation. It doesn't make you constrict, okay? Phosphodiesterase does not constrict the bronchioles. It just brings you back to normal, okay? Cholinergic will constrict you. Albuterol or sympathomimetic, or AKA adrenergic, will dilate you. And phosphodiesterase brings you back to normal tone. All right. So if we take a bronchodilator and take an xanthine, right, we can keep you from going back to normal and keep you from constricting. All right. So we're just throwing different medicines in there to cause different things. But I don't want you to say, well, I thought phosphodiesterase is what constricts you. No, it doesn't constrict you. It just goes back to normal. Okay. Cholinergic response is what constricts you. All right. And so in that case, we want to take a parasympatholytic or a anticholinergic that will stop you from constricting. Okay. Make sure you go back and listen to this. All right. Now, some of the side effects of that will be dry mouth. Pretty much the only side effect of it is a dry mouth. And we usually use it in conjunction with albuterol. All right. That's the first medicine that is an anticholinergic. And there's only one more. The second medicine that's an anticholinergic is atropine. Atropine. Atropine is usually given because the patient's heart rate went down. If you have a patient and they become very bradycardic, the nurse is going to rush in and give atropine. Because what does the cholinergic response do to the heart rate? Somebody tell me, what does the cholinergic response do to the heart rate?
Restricts.
Huh?
Does it relaxes it?
What does it do to the rate, the heart rate? What happens if you, the cholinergic response, huh?
Decrease.
Decrease, good. The heart rate's gonna decrease. And so if somebody has a low heart rate or if they have the cholinergic response is dropping their heart rate, if their heart rate start dropping because of cholinergic response, we need to hurry up and find an anticholinergic to stop that, right? So that's what we do. Atropine is the drug that was made as an anticholinergic to increase the heart rate. It's going to make it go back up because it blocks the effects of cholinergic. Okay? So there's only two medicines on the parasympatholytic side or the anticholinergic side, and that's Atrovent and atropine. Atrovent is ipratropium bromide, is the one we inhale with albuterol. Atropine is an IV that you give to increase the heart rate. Okay? Look at it. Atropine sulfate is frequently used in surgery because a lot of times in surgery, patients' heart rate start to drop because of the what? Why would somebody's heart rate start dropping in surgery? What do you think is causing that?
Blood loss.
It could be blood loss, but
loss.
what? Blood loss, good. But what about if it's not blood loss? What's something else? Why would their heart rate be dropping? What would be something that's going on during surgery?
Medication and
What kind
the
of
fact that
medication?
they under
Anesthesia.
There you go. Anesthesia. You got them zonked out, right? You got them in surgery. They got to be completely knocked out, right? So you got them on sedation. You got them on paralytic drugs to keep them from moving, right? So you got to breathe for them because they ain't breathing because you paralyzed their breathing, right? So the anesthesiologist has to breathe for you while he or she is giving you all these medicines, right? And so if I'm giving you all this sedation and pain medication, it's going to drop your heart rate. It can drop your heart rate. That's why I call it overdose. You know, you start falling out, heart rate starts slowing down, people die from an overdose. But in a controlled situation, it's okay. If I'm under the knife and the anesthesia is right behind me, then I'm fine with being overdosed, right? That's what we're doing. We're dosing you up so much where your heart rate starts to drop. So we need atropine going to keep that heart rate from dropping, okay? That's why we use atropine in surgery. It blocks the production of cGMP just like the other thing does, right? Because cholinergic response produces cGMP, which makes constriction, right? Or heart rate drop, pupils constrict, all that cGMP does all of that. And so if we want to block that, we need to give an anticholinergic, right? And it's just two of them, Atrovent and atropine. Now, some of the contraindications of atropine. Why would I not give atropine? Well, if somebody has a sensitivity to it, like they so sensitive that the heart rate shoot up to 200, right? We don't want that. Glaucoma. If somebody has glaucoma, we don't want to use atropine because atropine is going to, because cholinergic will constrict the pupil. Atropine is going to stop that from happening, right? It's going to block that, so it may even dilate a little bit. Because that's not on deck. So if the parasympathetic nervous system is not there, then the adrenergic side is taking over, right? So if the parasympathetic or cholinergic response is to constrict the pupils, and that's not there anymore, it's not going to constrict. They're going to just start opening up because they have nothing to constrict them, right? And somebody who has glaucoma already has an issue with their pupils, so you don't want to give them atropine. Tachycardia. Of course, if I give them atropine, I'm giving it to them so that their heart rate will go back up, but it could go up too high, okay? So those are some of the contraindications you want to be careful because there's no reason for me to give them atropine if their heart rate is already up, right? We only give it because we're worried about the heart rate dropping, or like you said, blood loss makes the heart rate go down slow. We want to give some atropine. But if they already have tachycardia, there's no need to give atropine. All right. Side effects. Dilated pupils. Of course they're dilated because there's nothing there to constrict them. You have blocked that side of the nervous system that will constrict them. So now sympathetic nervous system is working all by itself. And so that means it's going to open up. Thick drying of secretions. We said some of the side effects of an anticholinergic is dry mouth. So not only dry mouth, but your secretions are going to start drying, right? Dry mouth, palpitations, and tachycardia. So when you think about that, when you have a list of side effects, just think about what you're dealing with and see what side effects match what you're dealing with. You don't have to remember, oh, those 3 and this 4. Don't try to remember it like that. Just know what you're talking about. If I know what atropine is, it is an anticholinergic. All right, it's going to block the effects of acetylcholine, right? Well, let me think. If they're asking me for side effects, I'm going to look over here and say, okay, this is what happens if I have cholinergic. So if I have an anticholinergic on deck, then the opposite of that is going to happen. So that's how you choose your answers. All right. Please don't try to memorize. You don't, every word. I remember that word. I remember this word goes with this one. This is not how you learn this. You need to learn the route. You need to learn the science behind it. So then it don't matter what side effect they throw at you. You'll know which side that must come from, okay? You'll know which side that must come from. If I talk about heart rate shooting up, if I say bronchodilation, you don't have to memorize that that's beta 2. You just memorize that's a sympathetic nervous system thing. That happens when you activate the sympathetic nervous system, period. You know that, and you know how it happens. So then you don't have to memorize, okay? Last one for the day is corticosteroids. This is another category of drugs, corticosteroids. Like you said earlier, Ms. Cummings, we do give steroids, and steroids are given for what? Read number 1, Ms. Cummings. Maybe she stepped away. Ms. Woods, read number 1 for us.
It's used in the management of the inflammatory process.
There you go. Corticosteroids are inhaled steroids that are used for the management of inflammation associated with asthma, reactive airway disease, and other pulmonary disorders. So any kind of pulmonary disorder that causes inflammation, we can give corticosteroids. Okay? Corticosteroids. Let me see. Now look, the corticosteroids game is 5, well, it's really 4. Let me see. 1, 2, 3, 4, 5. About 5 of the corticosteroids that we inhale and 1 that you take as a pill. All right, we're going to do the corticosteroids and then we're going to stop for the day. So we look at our categories. Breathing treatment or airway pharmacology categories. We have the specific bronchodilators, right, which are the adrenergic bronchodilators. We've got methylxanthines or the xanthines. We've got anticholinergic category. And now you're learning the corticosteroid drugs. Each one of those categories have its own drugs that you got to know. For instance, xanthines. What are the 2 drugs that are xanthines? Anybody? What are the 2 drugs? Huh? Theophylline?
Theophylline and
Alphalin. Yeah. Theophylline and aminoalphalin. Those are the 2 methylxanthines. Methylxanthines work by blocking who? Who do the xanthines block? Anybody?
The phosphodiesterase. I don't know how to pronounce it.
Phosphodiesterase. The methylxanthines or xanthines block phosphodiesterase. Okay. What about the anticholinergic? What drugs are anticholinergic drugs? There's only 2 of them.
Atrovent and atropine.
Atrovent and atropine. Okay. And then, of course, there's several of the adrenergic bronchodilators that you just learned. You need to know all of those. All right. And now we're getting ready to talk about the corticosteroids. Corticosteroids. These are used for inflammation, either orally or aerosolized. Okay. Now, there are some side effects that you need to know about steroids, whether they're oral or aerosolized. There are some side effects. The inhaled side effects are oral candidiasis. What is that? Who knows what that is? What's the other word for that? Candidiasis is thrush. You ever heard of thrush?
I have.
Yes, thrush is in your baby, right? Sometimes our babies have that white stuff in your baby's mouth. That's thrush. Okay, it can be painful. It's just like fungus in the mouth. Okay, that's thrush. So that's oral candidiasis. If you don't tell your patient to rinse their mouth out after they take a steroid, they could develop thrush. Okay, throat irritation is another one of the inhaled side effects of inhaled steroids. And then dry mouth. Okay, now that's the inhaled. Systemic drug is the one that you take the pill. Systemic means by mouth, right? You took a pill or IV or whatever. The pill or systemic side effects of corticosteroids is Cushing's syndrome. And I forgot what all that is, but don't worry, just know it's Cushing's syndrome. Also, immunosuppression and diabetes. Cushing's syndrome, immunosuppression, and diabetes. That's why they say you don't want to put you on steroids for too long, because steroids can suppress your immune system. So somebody that's on steroids has a higher chance of becoming infected by anything out there because their immune system is suppressed. All right? Steroids will suppress your immune system. I say, get out that kitchen. And diabetes, okay? Those are the two sets of side effects. You got inhaled side effects and systemic. Now, let's look at the aerosolized steroids, and there's only one pill, okay? There's only one that's a pill. The other ones are inhaled. So the aerosolized steroid, the first one is dexamethasone. I'm sure you heard of that one on the news, right? We use that one in the news. They were using that one for coronavirus, right? Coronavirus. A lot of people were trying to say, oh, Decadron or dexamethasone steroid. Let's get that. That's what the president was talking about. He used that. They gave him large doses of dexamethasone to try to fight coronavirus. That is the generic name for Decadron. Dexamethasone is the generic name for Decadron. It comes in the MDI as 84 unit grams per puff. The dosage is 3 to 4 puffs, 3 to 4 times a day. And try not to exceed 12 puffs per day. That is Decadron. That is one of the aerosolized steroids. The next aerosolized steroid is beclomethasone dipropionate. Beclomethasone, also known as Ventsoril or Beclovent. So beclomethasone is the generic name for Ventsoril and Beclovent. It's in an MDI form as well, 42 unit grams per puff, 2 to 3 puffs a day, not to exceed 12 puffs a day. The next one is flunasolide. Flunasolide is the generic name for Aerobid. This is another aerosolized steroid that comes in the MDI at 250 unit grams per inhalation. You give 2 puffs twice a day. Don't exceed those 4 puffs. The next one is trimisolone. Trimisolone. Trimisolone is the generic name for Asmacort or Pulmicort. You'll hear this one a lot. Pulmicort is one we use in the hospital a lot. I don't know if I have any Pulmicort. Do I have any Pulmicort? It's in an orange. It has an orange label on it. No, I don't have any Pulmicort. Pulmicort. Now I don't have any. I have some budesonide. Budesonide is also a steroid, but I don't have any Pulmicort. Okay, the next one is fluconazole. Fluticasone. Fluticasone propionate. Notice I don't say these second words. They're not that important. As long as you know the first one is okay. But fluticasone is, which you probably heard, is Flovent. Fluticasone is a inhaled steroid. It's the generic name for Flovent. Flovent. Okay, it comes in an MDI and provides 44, 110, or 220 unigrams per inhalation. So you can select. They got Flovent 44, Flovent 110, or Flovent 220. You just pick whichever one, whatever the one doctor gives you. The one that's 44 unigrams is for mild asthma, and for people who have severe asthma, they get the 220 dose. Okay. Fluticasone. Propionate is the generic name for Flovent. We are talking about inhaled steroids. And then finally, in the end of the day, we have an oral steroid that we'll talk about, and that is prednisone. Prednisone is the oral steroid that we take, okay, by a pill. The action is to reduce inflammation and potentiation of sympathomimetics. So if we give a aerosolized steroid like prednisone, a pill, that if you give the patient a pill, which is prednisone, right, and they're getting breathing treatments, it will enhance the effects of the breathing treatment. It has the effects of sympathomimetics, see, potentiation. So it adds to the effects of the sympathomimetics, which are the adrenergic bronchodilators that you learn. All of those, Albuterol, Bronchosol, all of those are enhanced if you give an oral steroid as well. Okay, if you give it to them at the same time or whatever, it's in the system. Okay, the dosage, again, with the oral steroids, we have to have a loading dose. Now, have you guys ever heard of that dose pack that you get from the doctor where you came down with a nasty little upper respiratory infection and they give you this little medicine pack that's got, they say Monday you take all 6 of these, Tuesday you take 4, Wednesday you take 2, Thursday you take 1. Have you ever seen that kind of pill pack?
Yes.
Okay. Well, that's what you call a load. That first day is your loading dose. Okay. We're going to give you a nice amount for the first day. And then, of course, you don't check your blood when you're at home, but it's similar to that. Okay. So in the hospital or whatever, they give you a loading dose. The loading dose is 4 milligrams per kilogram of body weight. The loading dose for prednisone is 4 milligrams for every kilogram of body weight. Okay, so if somebody weighs, or a dog or something is 20 kilograms, you're going to give them 80 milligrams, right? It's 20 times 4 is 80, yeah. So if they're 4 milligrams for every kilogram, okay, of body weight. If they only weigh 1 kilogram, you give them 4 milligrams, okay? If they weigh 2 kilograms, you give them 8 milligrams. Okay, and of course, they're going to be way bigger than that. So we're just trying to show you how the math works. That's the loading dose. We're going to give them a massive dose first, right up front. And then we're going to maintain them, checking their levels of prednisone. So the therapeutic serum level for prednisone is 100 to 150 micrograms per deciliter, or 100 milliliters of blood, which is a deciliter. Okay. Therapeutic serum levels of prednisone is 100 to 150 deciliters, right? Micrograms per deciliter. That's what we're looking for. If I check your blood and you are less than 100, then I'm going to give you a maintenance dose of 1 milligram per kilogram, okay? The loading dose is 4 milligrams for every kilogram of body weight that you are. But when I check you later or the next day and I see that your levels have dropped to less than 100, then I'm going to give you 1 milligram for every kilogram you weigh as a maintenance dose, okay? Just to boost you back up to therapeutic range. That's how I boost you back up to therapeutic range. And we can give oral prednisone for 2 to 3 weeks period or long term to manage a patient's condition more adequately. All right, guys, that is a amount of stuff you learned today. You learned a couple of different categories. You learned the sympathomimetic category. You learned the xanthine category. You learned the anticholinergic category, and you learned the corticosteroid category, okay? And the corticosteroid, of course, has inhaled and systemic, right? You learned the aerosol or inhaled corticosteroids. And then I told you the last one, which is the only oral, is prednisone. Please spend your day going back over this information, writing your note cards, and being in the reading. I promise you, the Airway Pharmacology chapter is vital to your test. If you don't look at that, you're going to bomb this test, okay? Even if it wasn't in the book, it's already hard enough because there's so much information and we're not done, okay? So you stop here. I want you to go and work on that tonight. Homework will be homework number 1 and 2 from the pharmacology homework packet. Homework 1 and 2, okay? If it's something in there that you haven't gone over, try to find that in your reading, all right? But homework 1 and 2 is due tonight, okay? Due tonight for your homework. Do that, read, go back over this if you need to. If you're live, you won't need to go back over the lecture, but it's here for you. If you want to go back and look at while you're taking your notes or whatever you need to do, it's being recorded. But make sure you study, 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 because tomorrow we're going to go into long-acting bronchodilators, right? These are the dilators that last for 12 hours or more, okay? So you got some long-acting bronchodilators you got to know. There's some prophylactic medicines that we're going to talk about, right? And prophylactic means preventative, right? Leukotriene inhibitors that you got to learn about. See these? Antimicrobial agents that we have to talk about. Antiviral, antiprotozoal, surfactant replacement therapy, right? And then that's it. Then after that, we're going to talk about the small volume nebulizer, the MDIs, the dry powder, the spacers. You got to know about all of that. And then it's done, okay? Well, no, it's not done. Then you got the mucolytics, the mucokinetics or the mucolytic stuff that move mucus, right? Which is the not only the isotonic saline, but hypertonic saline, hypotonic saline. Then you have the actual prescription mucolytics like Mucomyst, sodium bicarb, Dornavac, Dornase alpha. Then you have your surface acting drugs, which is alcohol. I know you didn't know that we used to nebulize vodka, okay? Just take some vodka and put it in a nebulizer. It has its reasons. We used to do that, and they do it every now and then. But aerosolized vodka, not only will it get you drunk really quick, right? But it can harm you if you're doing it for recreational use, right? You don't have the stomach ache and all that because you didn't drink it. You just inhaled it. But there's reasons why we do it, okay? Surface acting drugs. And then that will be it. So you see, there's a lot left. A lot left. And I'm stopping now. Probably should keep going. But I'm stopping now because I know I have given you a lot for today. So be here bright and early, 8 o'clock in the morning. And we will look for your announcements tonight, whether I'm going to be on campus or not. Because you don't have to be. But I'm just saying, you know, some people like to come to campus if I'm going to be there. But I might not be there tomorrow. I may be just like this. But either way it goes, be logged in at 8 o'clock so we can continue on. We're going to cover a lot tomorrow because we got a lot going on, okay? Good job today. Some of your answers were right on point. You're understanding because you're keeping up with it. Study it and don't play with it, and you will be fine, okay? Have a good day.